time for our yet another fantastic monthly webinar. I would like to acknowledge the Mexican Pediatric Ophthalmology Association in particular, and the IPOSC team, the training committee for putting together another fantastic webinar, and also to our hosts, the AAO team, to putting this together and allowing this webinar to go live one more time. While we have amazing speakers, as always, and just a quick reminder that please do, throughout the webinar, you are able to ask your questions through the Q&A. The chat pod is also open, so for social comments, please continue to use that. But if you have a particular question, try to use the Q&A if you would, so that the moderators and the speakers will be able to see your questions directly. Right now we have more than 210 participants and counting. With that, I would like to give a quick update of the IPOSC one more time. And as you well know, IPOSC is a 90+ member society and organization representing more than 20,000 individuals worldwide. I would like to, as always, acknowledge our past presidents for all the things that they have done and continue to do so. This is the current board of directors. The flag is going to be handed over this July, and we will reach out to all our representatives for our upcoming nomination and voting for our upcoming vice president. The executive committee has decided to nominate Dr. Tamara Vignansi-Jaffe from Israel to be nominated for the vice president role, and you will hear about that soon. Also would like to acknowledge the advisory board, the leaders, and the board members themselves for all the phenomenal work that they do. As you well know, we have many committees, and I'm going to go through them very quickly and maybe mention some of the activities as an update. The ROP committee continues to be very active. As you well know, under the ROP particularly, there are 3 subcommittees. Would like to particularly one more time acknowledge the International Classification of ROP, the 3rd edition, and has been published and been presented in the last IPOSC meeting, and you've heard. I wanted to also particularly acknowledge our fantastic leader from Mexico, Maria Ana Martinez Castellanos, as she has been an integral part of this fantastic organization. The CIBA continues to be moving ahead. Now that the 3 centers, as you well know, of focuses have been established and the training has begun. This was possible by amazing donations, and particularly from the Knights Templar Eye Foundation, to make sure that all the equipment and the facilities were ready to go as centers of focus. The IPOSC Training and Education Committee, just like you're seeing right now, is very active on our monthly webinars. And I would like to particularly acknowledge Dr. J.C. Yam and Sonal Farzavandi, as well as Satya Agagulyan, for their tireless work, and on top of the webinars like you're seeing right now and a part of, they have been expanding the worldwide education for pediatric ophthalmology. 2 new committees, the IPET, the Pediatric Eye Care Team committee leaders initiated the first orthoptic training in Gambia. They're gearing up to start the training for a 12-month training for the certification program. And this project fully funded at this point, but we are hoping to expand the funding as the expenses have now have increased a little bit. And also we are organizing the team members for the vision screening committee, and IPOSC, particularly with the CF of IPOSC, has been supportive in this initiative. The newest committee is so appropriate to be mentioned in particular, in this webinar is the Smartphone ROP Committee. This amazing committee has already been working together. All the countries are represented in this South America-led Smartphone ROP Committee, initiated by Dr. Alejandro Vasquez, and current president is Pedro Acevedo from Colombia. Obviously, Guillermo and Gabriela from Argentina, particularly Gabriela is the inventor of the Keeler MIO. And we mentioned Mariana and as well as Andrea. Utilization of the SBROP, they've been doing this to document, teach, and follow up the ROP patients. Mariana also initiated an amazing work incorporating the Microsoft team. They are right now ready to roll the first app that is to do with the ROP and will be tested in few sites, as well as the Case Western Reserve. Stay tuned we do have a new administrative team. Thank you for your patience as we transition into the new team. They have been phenomenal. They are overseeing not only the IPOSC, but also APOS, as well as the CF of APOS. They did a great job in the APOS meeting, and they will be handling our communications project oversight and finance. And you will see a new website very soon, and we will be receiving donations much more easily through that. Together, we have much to do. Please apply to volunteer to our various committees, and you can apply by sending an email or reaching out to the committee chairs in particular, so they can guide you on their endeavors. With that, without further ado, I would like to introduce our moderators. Obviously, Sonal Farzavandi does not need any introduction, and as I mentioned, she is the immediate past president of IPOSC, and also a senior consultant in the Singapore National Eye Center. And it's an honor to have Dr. Mario Najera as the local moderator. He is also the professor in pediatric ophthalmology and strabismus, and current president of Mexican Association of Pediatric Ophthalmology, and the professor and former chief of strabismus department at the Hospital de la Luz, Mexico City, Mexico. And with that, I would like to hand it over to our moderators, and thank you for being with us one more time.
Thank you for your introduction, Dr. Faruk Orge. We, as the Mexican Association of Pediatric Ophthalmology, are very pleased to be co-hosting this webinar organized by the IPOSC. So it's a pleasure for us to be here. And I would like to introduce a little bit of our Mexican Association of Pediatric Ophthalmology. Our association was founded back in 25 years ago in 1997. We do have over 100 active pediatric ophthalmology members, and our association is affiliated to the Mexican Society of Ophthalmology, which is the main one in our country, and it has over 4,000 ophthalmologists as members. Our association has an academic program. It consists on monthly academic sessions. And since the beginning of the pandemic, we have doing those sessions virtually, but hopefully in two months, we will start doing online. And it will be hybrid also for those around the country and even out of the country. We will also have an International Update Congress. It was held actually last November, and it was very successful. We do this kind of the International Congress every 2 years. And the Mexican Association of Pediatric Ophthalmology actively participates in Update Congress and also works very close to pediatricians, as they are the first contact doctors for our children. So we always try to promote early detection programs on every topic in pediatric ophthalmology, especially in amblyopia, pediatric cataracts, and strabismus. Actually, the main Congress of Mexico is always the National Mexican Congress, and it will be in June in Merida. So you are all invited, and the AMOP will participate in the subspecialty day and also in some symposiums. I would like to thank also my board that is composed with me as president, also Dr. Luis Cárdenas as the vice president, Dr. Zaira Bernal as our secretary, and Dr. Eva Lopez in our treasury department. So finally, I would like to thank to the International Pediatric Ophthalmology and Strabismus Council, led by Dr. Faruk Orge as the president, for your invitation to us to participate to co-host this webinar. We have prepared a very nice program, thanks to Dr. Sonal Farsebandi, that will be also our co-moderator, and also to Dr. Jason Jam, that he will be helping us. So we would like to launch our webinar. It will be about treatment approach on special strabismus. And we do have very, very good speakers. They are experts around the world. And our first talk will be about treatment approach on Duane syndrome with the Dr. Rohit Saxena from India. So please, Dr. Rohit, go ahead with your talk. Thank you for your attention.
Hello friends, greetings from New Delhi. I am Dr. Rohit Saxena and I'll be presenting on Duane syndrome. While understanding Duane syndrome can be quite a challenge, the basic pathophysiology is that there is nil or subnormal innervation to the lateral rectus from the sixth nerve nucleus. The lateral rectus starts getting some abnormal innervation from the third nerve, particularly the medial rectus subunit. This results in subnormal medial rectus innervation and can possibly lead to secondary muscle changes in the form of medial rectus fibrosis or superior rectus contracture. While the pathophysiology is similar, the presentation can be quite variable, requiring a unique approach for each case. The overall aim of surgery would be to reduce deviation in primary position, to eliminate abnormal head position, disfiguring retraction, or upshoots or downshoots. This was a 14-year-old girl who came to us with inward deviation of the left eye since birth. She had a modest face turn and a small 20 prisms iso-deviation in primary gaze. You can see the retraction on adduction and the limitation of abduction with widening palpebral fissure. Now, while each case needs to be individualized, overall, we can see that in a case of unilateral iso-Duanes with small angle esotropia, you can get away with a small medial rectus recession of the involved eye or a vertical rectus transposition. If the deviation is moderate or more, you would require to do a bimedial recession, asymmetric with more recession in the contralateral eye, or medial rectus recession with a vertical rectus transposition of the involved eye. In the presence of a severe moderate or severe co-contraction with iso-Duanes, you would need to do these procedures along with a lateral rectus recession with Y-split. In these conditions, you would have to actually do much larger correction for esotropia because of the added lateral rectus recession. In bilateral cases, you would need to do this procedure in both the eyes. So in this case of small angle esotropia, we did in the ipsilateral medial rectus recession of 5 millimeters. You can see good correction of alignment in primary gaze. However, the presence of adduction deficit, which can particularly be troublesome if you do large medial recti recessions of the involved eye. So we do not do large MR recessions of the involved eye. They can result in adduction deficit and diplopia in the opposite gaze. And if there is significant retraction to start off with, they can actually develop a synergistic divergence in the post-op period. You need to titrate the amount of medial rectus recession based on the force duction test, but would not advise to do recessions more than 5 millimeters. This is another girl with left Duane's with a little larger, about 30% of esotropia in primary case, with a significant head posture. In this case, we did a moderate amount of medial rectus recession along with a vertical rectus transposition, which was a superior rectus transposition in this case. You can see good alignment, moderate adduction deficit, but the key we note is significant improvement in abduction, which is what you can see as an advantage of transposition. So greater abduction versus medial rectus recession alone. Less amount of medial rectus recession is necessary, so less adduction limitations would be seen in the post-op period. Possibly there may be lower amount of post-op drift or recurrence of esotropia, but please remember, do not do vertical recti transpositions if there is retraction or co-contraction that is present. Of the muscle transposition procedures, that is superior rectus transposition versus both the vertical recti transpositions, it is the results of both are quite comparable, but a superior rectus transposition is advantageous because you're actually moving only one muscle, and if you need to add that with the medial rectus transposition, it would reduce the risk of anterior segment ischemia, whereas if you have to operate both the vertical recti, there is a significant risk of anterior segment ischemia. In this case, you would consider doing partial vertical rectus transpositions and only transpose the lateral halves of the vertical recti. Resections in Duane's, although have been conventionally stated to be contraindicated, however, recent reports have talked about small resections of plications, not more than 3.5 millimeters in cases of Duane's. Remember, it is only possible or advisable to do small resections if there is no co-contraction. Otherwise, you actually worsen the co-contraction and result in a worse post-op outcome. In cases of bilateral Duane's, you need to do these procedures in both the eyes. So in this case of a bilateral Duane's, we did bimedial recession to get good alignment. In a patient of bilateral Duane's with fusion preoperatively, you need to be very careful because surgery can be a little unpredictable in these cases of bilateral Duane's. So only operate if there is a clear indication for surgery. In cases of Duane's with retraction, so you can see a small amount of esotropia with significant retraction, you need to recess both the medial rectus and the lateral rectus of the involved eye. So in this case, we did both MR and LR recession. You can see improvement in primary gaze alignment along with reduction in esotropia. If the ESO deviation was much larger, you may have had to do a bimedial recession along with the lateral rectus recession. So the medial rectus recession is planned for the esotropia and the lateral rectus recession for the co-contraction. And you may have to do a much larger MR recession to overcome the lateral rectus surgery. Duane's can be quite challenging because they often present with severe co-contractions like in this case. So exo deviation in primary gaze and severe co-contraction on adduction. So if you need to actually look for the presence of lateral rectus activity in these cases and the presence of shoots. So if there are no shoots, you can get away with a large lateral rectus recession. But in the presence of retraction or shoots, you would need to do a lateral rectus recession with a Y split or do a very severe procedure like the lateral rectus periosteal fixation with or without vertical rectus transposition. So in this case where we had Duane's with severe co-contraction, we did a left lateral rectus periosteal fixation, and you can see good alignment in primary gaze with marked improvement in the retraction and the shoots. Another case of right Duane's, you can see exotropia in primary gaze and severe co-contraction. In this case, we did a lateral rectus periosteal fixation along with a partial vertical rectus transposition. Now, when would we like to add a partial vertical rectus transposition? So you look for the abduction. If present, you may require to add a partial vertical rectus transposition. So here there was minimal abduction. We got away with just a periosteal fixation to the lateral orbital wall. But where in cases you have good abduction to start off with, you need to add a partial vertical rectus transposition to prevent consecutive esotropia and retain some amount of abduction. In some cases of severe Duane's, you may have a hypertropia even in primary case. So this is actually showing a severe co-contraction, which is present even in primary gaze. And before deciding on vertical rectus surgery, you need to do a lateral rectus disinsertion from the globe and do a forced duction test for the superior rectus. Unless the superior rectus is tight, you can just get away with a lateral rectus periosteal fixation like in this case. And there was no post-op vertical deviation and no vertical rectus surgery was required. So therefore, managing an exo-Duane's, it's important to remember that you would have to do large lateral rectus recessions and sometimes even do a periosteal fixation, which is virtually like an infinite recession of the lateral rectus. In ortho-Duane's, unless there is severe co-contraction, you may require no surgery and you can just let the patient follow up. So ortho-Duane's, in the absence of co-contraction, no intervention is required. If there is associated retraction, you may have to do asymmetric recessions of both the medial rectus and the lateral rectus of the involved eye to prevent a post-operative strabismus from developing and manage the retraction. In the presence of shoots, you may have to do a Y-split of the lateral rectus along with a recession of the medial rectus. So the take-home message for Duane's is that there are clear-cut indications for surgery because there is only as much we can improve the patient by. Normal reductions in versions cannot be achieved, and that must be explained to all patients preoperatively. The aim is to get good primary gaze alignment, increase the area of binocular single vision, decrease the shoots and retraction, which can really never be completely eliminated, and wait till the child is walking unless there is a risk of amblyopia so that you are able to assess for the head post stress. Thank you very much for the opportunity and the attention. So, thank you, SPOS, for the opportunity and the chance to present. Questions, if we could take any.
Thank you so much, Rohit. I think the people are just getting familiarized with the Q&A box. So could I just post one question to you in the meantime? You spoke about exo-Duane's and about periosteal fixation of the lateral rectus. When in your experience would you still consider the Y-split of the lateral rectus and a recession for which kind of an exo-Duane's?
So if there is significant upshoots or downshoots, I would prefer a Y-split, which should be always accompanied by a recession of the lateral rectus. So you need to recess at least some amount of the lateral rectus when you're doing a Y-split. But if there is a lot of retraction and shoots, I would do a much larger recession, would be maybe up to 9 millimeters, along with a Y-split of about 20 millimeters. In the presence of co-contraction causing retraction or a vertical deviation, as we saw even in the primary position, I would probably go ahead with do a periosteal fixation. And as I mentioned, would add partial vertical rectus transposition if there is abduction to start off with.
Thank you. We have one question which has come up in the Q&A. If I could ask you quickly, would you prefer superior rectus recession if there is a hypertropia in the primary position?
So I would not do a superior rectus recession in the first go, because most often than not, these are due to the co-contractions. But over time, there could be a superior rectus contracture, which may result in a post-op hypertropia. So after doing a disinsertion of the lateral rectus, I would do a forced duction test for the superior rectus. If that is free, then I would just retain my original surgery of doing a very large lateral rectus recession or periosteal fixation. And subsequently, if there is a vertical deviation, then I would plan a superior rectus recession. But in most cases, I have not required a superior rectus recession.
Yeah. Thank you so much, Rohit. There's some more questions coming for you, so you could answer them by type answering them. Thank you so much for the excellent presentation. We will now move on to our next speaker, who is Dr. Luis Xavier Cárdenas Lamas. He's from Mexico, and he's going to talk to us on Brown syndrome. Dr. Luis, please.
Hello, I'm Luis Cárdenas. Welcome to Mexico. I'm going to share my presentation. Thank you, IPOSC, for the invitation to this webinar in conjunction with Mexican Association for Pediatric Ophthalmology. Today, we are going to talk about Brown syndrome. And I want to dedicate this presentation to our IPOSC friends in Russia. We send you all our love. Okay, Brown established that this syndrome was determined by a congenital anomaly of the supraoblique tendon sheath, which would be short and not existent. Today, we know that it could be secondary to anomalies of the supraoblique tendon or of the trochlea, inflammatory disease, infection, trauma, or neoplasms. The clinical features are elevation is limited of the affected eye in adduction, abnormal head posture with raised chin, divergence in gaze, hypotropia in primary position. The limitation of the elevation in Brown syndrome is severe in adduction, moderate in supraadduction, and mild or absent in supraabduction. The surgical criteria are the vertical deviation in the primary gaze position, abnormal head posture, diplopia, and downshot in adduction. And there are a lot of surgical techniques, superior oblique tenectomy, superior oblique tenotomy, the tendon lightening, and the expanders. Personally, I like the superior oblique tenectomy, and I will talk about this. So my first case, I will turn off my video to let the presentation runs better. My first case of this morning is a 3 years male consults for an esodiation. He has left hypertropia and right hypotropia with a very important limitation of the elevation in adduction and an abnormal head posture. In these pictures, we can see the limitation of the elevation in adduction and in the midline. In the video, we can see again the limitation of the elevation and the limitation of the elevation in adduction. Remember the divergence in superversion and the typical B pattern of the Brown syndrome. Our treatment plan was a right superior oblique tenectomy. I will show my personal technique. First, we always try to do the forced adductions to release the oblique. If it's not possible, we start the surgery, we put a traction suture. Then we take the superior rectus, we look for the oblique fibers up to the vorticus vein. We take it with another hook. Then I cut from the sclera and passed under the superior rectus. Then we open the sheath and cut the tendon as far back as possible. The next day, we see how the limitation of the elevation improved both in adduction line and in the middle line. As a reminder, when we take the superior rectus, being carefully not to catch the superior oblique in the rectus hook. Here we can see how, when pulling the superior rectus, it is observed on the eyelids, the superior oblique. And remember to take the complete fibers of superior oblique and a minute. Take the complete fibers of the superior oblique, as we can see in this video. And don't forget to cut the tendon as far back as possible. Okay, 6 years later, the same patient came due to abnormal head position, and in the examination, we observed an inferior oblique overaction of the right eye. According to the mother, it has been evolving for 6 months. This is a secondary complication to the tenectomy that can occur even at the day after the surgery. Some authors recommend the surgery of the inferior oblique at the same surgical time of the tenectomy. Particularly, I don't do it in the same time. My second patient this morning, she also presents an abnormal head posture and diplopia. We can see the limitation of the elevation in adduction and the limitation of the elevation in the midline. So we did the same procedure. The next day, we can observe the improvement of the elevation in adduction and in the midline. We can observe an inferior oblique overaction, but does not produce symptoms. Finally, the differential diagnosis of Brown syndrome includes the inferior oblique palsy, which is also also presents with a limitation of the elevation in adduction, but here we can see the overaction of the superior oblique, and in these pictures we can see the limitation of the elevation in adduction and the typical A pattern. Remember the inferior oblique palsy when you have a Brown syndrome patient. So in summary, tenectomy is a safe technique for Brown syndrome. Remember the history of trauma and autoimmune disease. The indications for surgery are very important. The hypertropia in primary position, diplopia, and the abnormal head posture. And don't forget the inferior oblique palsy. So these pictures are from our last IPOSC meeting in Scottsdale. Life is better when we share with our friends. Remember the ISA meeting in Cancun on next September 2022. We hope to see you here in Mexico. Remember, in Mexico, we say, my home is your home. Thank you very much, IPOSC, for the invitation, and thank you for attending this morning, this webinar.
Hi, good morning. I will answer a question. The question is, would you do the tenectomy even if the patient is binocular? And my answer is, if the patient doesn't have deviation in primary position, but the patient had abnormal head posture and diplopia in the other gaze position, the answer is yes. But remember, don't do the tenectomy if the patient doesn't have the indication for the surgery. Thank you.
Thank you, Dr. Luis Cárdenas. Our next speaker will be Dr. Fernando Pérez from Mexico, and he will talk to us with a presentation about Moebius syndrome treatment approach. Please, Dr. Fernando Pérez, go ahead.
Hi, everyone. Good morning. My name is José Fernando Pérez. I'm from the Mexican Institute of Ophthalmology at Querétaro, Mexico. Good morning. I thank the invitation to the Mexican Association of Pediatric Ophthalmology and the International Pediatric Ophthalmology and Strabismus Council to participate in this webinar to talk about Moebius syndrome. As you know, Moebius syndrome has been described since the 1880s as a bilateral six-nerve paralysis. Moebius in 1884 described the first series of cases, and that's why it has his name. Currently, the responsible genes have already been identified, and it is known that it's produced by an ischemia or teratogenic alteration that affects the development of the cranial nerves nuclei at the level of the brainstem. Facial paralysis is very characteristic of this syndrome, giving a typical features of a poker face. And very frequently, these patients tend to be cataloged as with mental deficit when their IQ is usually within normal limits. There are many associations to systemic alterations, such as craniofacial malformations, transverse terminal defects, and orofacial alterations, among others. We are going to talk about some of these alterations in the next slides. I will present the results of a series of cases reported in Mexico at the National Institute of Pediatrics. I want to thank the authors for allowing me to share their experience with you. This series is of 38 patients, 24 of them male, with an average age of 20 months. We're going to see their experience in this talk. Here are the collage various of these patients with different spectrum of affection. Of the associated anomalies, the eyelids involvement are very frequent, such as epicanthus and entropion, even with corneal exposure in some severe cases. Lack of thalamus is also present as a sequela of the facial paralysis. In this series, in the central nervous system, the authors find a mild degree of psychomotor delay in most of the patients, probably due to a lack of stimulation, and other alterations such as hydrocephaly and other findings, as you can see. In addition to the lack of facial expression, there are micrognathia and retrognathia very frequently present in these cases. The association with Poland syndrome with changes at the pectoral muscle is also frequent, like you see in these photographs. And multiple formations of the oropharynx and gastrointestinal tract are also present. In the limbs, we find club foot, clinodactyly, and other alterations, as you see on those pictures. The main ocular findings are the important limitation of abductions, frequently involving also diversion movement with bilateral paralysis, facial paralysis. As you can see in this video, this patient has ortho position with a typical poker face, expressionless, and he's also lack of abduction movement in both eyes. And a mild degree of adduction limitation also is present in this case. Okay, as we said, in the primary position of the gaze, the most frequent deviation is esotropia. Although there might be patients in ortho position and even cases of exotropia. Romero Apis in a series identifies 9 of 12 cases with esotropia, so that's the most frequent presentation. In the study that we are reviewing, the frequency of strabismus was 47% of the cases, and it was predominated by esotropia in 39% of this, ortho in a third part, and only 8% of exotropia. The magnitude of the strabismus in these cases is usually moderate, with an average of 30 diopters. But as you can see, we can go for a little deviation of 10 diopters in like a third part of the patients to a very large deviation of more than 45 diopters in only 10% of the cases. The limitation of abduction is given bilaterally due to the absence of the nucleus of the sixth nerve. And this is a typical finding on these cases. In many cases, a limitation of the horizontal version is added with a frozen gaze in primary position, but a certain degree of convergence preserved. That depends on the involvement at the brainstem. All patients have limitation of abduction, and 30% also in this series had limitation of adduction, which tells us of the greater commitment at the level of the horizontal gaze nucleus at the brainstem. The first adduction tests are very positive, reflecting the contracture of the internal rectus muscles. From the sensory point of view, if the patient is in an ortho position, they may have normal binocularity. If there is a deviation, this is altered, but they usually maintain good visual acuity due to cross fixation. The visual acuity, as we commented, is good in general, with a low frequency of amblyopia. As we've seen in this case series result, as you see, only 2 patients had no fixation of poor vision that reflects the low percentage of amblyopia in these cases. The differential diagnosis includes congenital esotropia, Duane syndrome, and the very rare true cases of sixth nerve palsy. Facial paralysis is bilateral in up to 90% of the cases in this series, and the sixth nerve is always bilateral. We can find other cranial pairs affected, like the 5th, the 4th, and the 12th nerves in that percentage. There's a low percentage, but you can find also these associations. The surgical treatment, the objective of this treatment in the cases with the strabismus will be to bring the eyes to the ortho position in the primary gaze. We will not be able to improve the abduction movement. The muscles are usually short and inextensive, and the risk of consecutive esotropia in these cases is low due to the lack of function of the lateral rectus. But there are cases that we can get a consecutive exotropia, so we must be alert of these cases. In conclusion, we have to do the proper diagnosis. We know that the esotropia in a moderate amount is the most common presentation in these cases, but we can get patients in ortho or even in exotropia in a small amount of patients. Limitation of abduction is frequently accompanied also with some degree of limitation of adduction. It is a disease that affects the version movement, the horizontal version of movement. So I want to thank you again for the invitation, and that will be all. Thank you very much again.
Hi everyone. Good morning here in Mexico City. I want to answer one question here in the Q&A. Pilar Marino, she's asking me about my experience, if any, with botulinum toxin in this kind of patient with Moebius syndrome. I have a very limited experience with toxin botulinum, but I think because of the characteristic of the muscle that is short and inextensive, and there is a muscle that is not normal, maybe the response is not full or is not the same as with congenital esotropia. But you can try that. I think we can try one shot of botulinum in the medial rectus, and if we don't have any effect, we can proceed with the surgery. Just remember that we most likely end with a frozen gaze in this kind of patients. Thank you again.
Thank you, Dr. José Fernando. That was a very interesting talk. We will now move on to our next speaker, who is Dr. Mario Najera, who's our co-moderator and president of the Mexican Society of Pediatric Ophthalmology. He's going to give us a talk on high myopia-related strabismus. Mario, please.
Hi, I'm Dr. Mario Najera, President of Asociación Mexicana de Oftalmología Pediátrica, and we are going to talk about high myopia-related strabismus. It is considered a pathological myopia is when the sphere is about -8 diopters or the action length is about 26.5 millimeters in those persons older than 9 years old. There have been some theories that could cause this kind of strabismus, but it was resolved at the end of the 90s through MRI images that show that in some patients there is a superior temporal staphyloma that produces an abnormal infiltration of the lateral rectus that dampens its adduction power, becoming more a depressor, and also produces an abnormal nasal displacement of the superior rectus because of this located globe through the staphyloma globe. There have been some authors that has proposed some different surgical techniques to correct this globe dislocation. And I have moved through the time for those techniques from Yamada, and for so many years, I prefer the Larsen technique with partial Jensen procedure. And since about 2010, 2011, my preferred one is the Yokoyama modified technique to correct these cases of globe dislocation in high myopia patient. This is a patient, a female patient, 60 years old, that was always in ortho position, that developed a progressive esotropia since 1 year ago with diplopia, as you can notice here. And on primary position, you can notice that he has a large esotropia of 50 diopters. And on version, he has limited abduction on left gaze for the left eye, and also a very mild limited abduction on the right gaze. And he has also a compromised elevation in both eyes. He has more myopia on the left eye, and he has good vision with contact lenses. Here are the images. These are CT scans images, and you can notice there is an infraplacement of both lateral rectus and also a nasal displacement of the superior rectus. And consider this, we have a diagnosis of heavy eye syndrome in this patient. So this is preoperatively. He has a large esotropia with a limited abduction in both eyes on lateral versions. So I decide to do hemi-Jensen between lateral rectus and superior rectus, both eyes, plus medial rectus recess of both eyes of 9 millimeters with a handbag on the left eye. Here is the patient 3 months after the surgery. He has strictly ortho, and he has maintained this ortho position for the last almost 12 years. This is a photo 4 years after the surgery. I hope he keeps that position through the time. There is another patient. This is a more severe case. This is a 60 years old female patient with a history of retinal detachment on right eye with 3 surgeries. You can notice here there is a scleral buckle, and she has also 2 vitrectomies, the last one with silicone. On primary position, you can notice this huge esotropia. She has an strabismus fixus disease related to high myopia. And as you can notice on version, the left eye doesn't move from there. She has a -8 limitation on left gaze. The left eye doesn't move upward and even downward. Here is the force reduction test I did to see if I was able to take the left eye out of there. As you can notice, the eye barely goes out. The force reduction test is positive 7 plus. And immediately when she starts moving her eyes, the left eye gets dislocated. So this is a Strabismus fixus disease. I decided to perform a Yokoyama modified technique on the left eye. The retinal surgeon didn't approve to touch or to take out the scleral buckle on the right eye, and she didn't want to get any surgery. With the surgery, you can notice in primary position, the left eye was already in primary position. From -8 on abduction, the left eye improved to -4 on left gaze, and she also improved a little bit on upper gaze and on down gazes. This is the surgery I performed on her. As you can notice, this is the forced adduction test. It was very positive under general anesthesia. This is the superior rectus that was displaced nasally, and notice the lateral rectus that is infraplacement, that it has an infraplacement position. After secure the muscle 12 millimeters back with a non-absorbable 5-0 Mercelen, I pull the eye as up as I could with a scleral pass to pull the lateral rectus up, and then I did the same with the superior rectus to pull the superior rectus as temporal as I could. In some severe cases like this one with a huge staphyloma, sometimes you are not able to take these patients the muscles right side by side. So in this case, I decide to pull a little bit more between the two Mercelen sutures to approach a little bit more the muscles. It was done with a fornix surgery approach. Then I recover. I took the medial rectus. You can notice that it was very tight and contracture. I used the right hood. Then I disinserted, and you can notice how the positive adduction test, forced adduction test, it was negative after that. I decided to do a medial rectus recess. I put the suture 8 millimeters back, and then a little handbag 4 millimeters for a total of 12 millimeters of medial rectus recess. You can notice how the forced adduction test improved. This is another patient, 52 years old, with a progressive esotropy since 2 years ago, and he has a very large anisometropia from the left eye. You can notice he has 40 diopters esotropy on the left eye and a very mild limitation of the adduction on left gaze for the left eye. On images, you can notice that there is no infraplacement of the lateral rectus, so there is a very huge posterior staphyloma, but the globe is not dislocated. So in this patient, I decide to go for an R&R in left eye, the normal one, and with good results. Here is another female patient, 50 years old, with progressive esotropia and diplopia since 1 year ago. She has also a very high anisometropic myopia, huge on the right eye. But as you can notice, there is almost none limitation on lateral gazes, and she has an esotropia of 40 diopters. So this patient didn't have any infraplacement of the lateral rectus, so the globe is not dislocated. So I decided to try 10 years ago when I saw her for the first time with botulinum toxin on medial rectus, both eyes. The first time I put 7.5 units on both medial rectus, and she was very happy with the result. This is the video before the first application, and after the application, she has no diplopia, and it lasts with good result with orthotropia for up to 5 to 12 months. So she has avoid the surgery, and she always want to get the botulinum toxin every 6 to 12 months for the last 10 years. And the last case, because sometimes we deal with esotropia also, This is a female, 20 years old, female patient with progressive esotropia, especially for the last 6 years, with a very high anisometropia on the left eye. She has a large esotropia of 45 to 50 diopters, and I decided to go with a R&R on the left eye with good results. The staphyloma in this case was posterior. So to conclude, high myopia strabismus patients, there are many different treatment options for selected cases. The preoperative image studies are very helpful. MRI is the best option, but CT scan is cheaper, especially for low-income patients. If the image studies shows a dislocated globe with displays of the lateral rectus and superior rectus, so a surgery technique to replace those vectors should be performed, plus a middle rectus recess is indicated. Some should say that it might be an option to go for the middle rectus recess on a second time, but I prefer to do it on the same surgery time. If the image doesn't show any dislocated globe, so there is an option for horizontal and regular R&R technique is enough for those kind of patients. But also the botulinum toxin could be an option for selected and recent and very early Moebius patients with very mild limitation. Consider that there is always a risk for scleral suture pass and scleral perforation because of the very tiny sclera in those patients. And there is always a risk of recurrence on long term on those patients. Thank you very much. Thank you for your attention. I would like to answer some questions. And there is one that if I do the Yokoyama first before recessing the medial rectus. Maybe 15 years ago, I used to do the medial rectus first. But then when I did the reposition surgery, even the Larsen technique or the Yokoyama, I always had to pull the eye in adduction in order to do it. So maybe since 15 years ago, I started doing first the Yokoyama or the Larsen technique without any problem. And I used to do the middle rectus recess after that. And there is also another question from Pilar Merino about the scleral pass and the risk of penetration of the globe. I always evaluate if I could do it. I prefer to do it, but if I see that the staphyloma is too much and the sclera is too tiny and blue, I don't do it. I always try to do it, and I might be doing the scleral pass in every 8 to 7 patients up to 10. So I will recommend to use for the scleral pass always a teleloop or the microscope. When I do that pass, I never do it by my own eyes. I always use a magnifier, even the microscope or a teleloop to do that. But if you don't think it's secure to do it, don't do it. So let's go with the next talk. This talk will be about strabismus after retinal detachment by Dr. Alejandro Armesto from Argentina. Please, Dr. Armesto, go ahead with your talk.
Good morning, everybody. I'd like to thank IPOSC for inviting me to join this webinar today. My talk will be about strabismus after retinal detachment surgery. Strabismus is a common complication after retinal detachment surgery, even after past plantar vitrectomy or cryotherapy as only procedure. It develops in up to 50% of operated patients. It's usually transient and results in 3 to 6 months' time. Nevertheless, strabismus persists in 5 to 25% of cases, and these are challenging cases. The causes of strabismus after retinal detachment surgery are mainly mechanical. due to muscle underaction or restriction, sometimes combination of both. Muscle underaction may be due to spontaneous muscle disinsertion, by reduction of the arc of contact of the muscle, by traumatic disinsertion of the muscle, by direct injury, or others. Restriction might be due to adhesions in the area of the exoplant between the muscle and the orbital tissues. The muscle might be shortened due to the presence of the exoplant. We can see conjunctival scarring or inadequate buccal placement. Also, a change in direction of forces, particularly regarding the superior oblique, might be present and have been reported many times. Sensory causes are not that frequent, and they are usually due to loss of fusion. I will show you a couple of cases now. This is a male. He had a right eye retinal detachment surgery with an encircling buckle, and he had horizontal diplopia after surgery. He had an exodeviation primary and a limitation of adduction of the right eye, as we can see here in the Lancaster screen test. As he had a slight deviation, he was treated with prisms. Another case, a female, she was highly myopic. She had a right eye retinal detachment surgery 2 years earlier, and her deviation progressed insidiously. She complained of gait instability, diplopia, and bad cosmesis. She also presented an exodeviation and right hypertropia in primary position and in other cases. The MRI of the orbits was not helpful, and when doing surgery, false adduction test was positive in all directions, so I performed a complete peritomy. I applied antimetabolites, and I performed an amniotic member graft to replace the scar conjunctiva. And this improved her single vision in almost gaze directions, particularly in the primary position. Another case, a female, she also was highly myopic. She had a left eye retinal detachment surgery 3 years before. She complained of progressive deviation and chronic redness of her left eye. She had this abnormal head posture with the chin up and the face right, and she also presented an exotropia with left hypertropia. You can see the redness of the left eye, and in the MRI findings, we could see this tissue here compromising the lateral rectus and the superior rectus. Forced adduction test was positive in all directions, so I performed dissection of the scar over the buccal between the lateral rectus and the superior rectus. I applied antimetabolites, and I verified the improvement in forced adduction test. The histopathology showed hyaline connective tissue with severe inflammatory reaction, and she was doing better after surgery. Another case, another female, she had congenital nystagmus. She was myopic in both eyes. She had nystagmus surgery 15 years earlier, and she had a right eye retinal detachment surgery 10 years earlier. As you can see, she had an abnormal head posture with the chin up and the face to the left, and her buccal was exposed at this level. She had a limitation of a deduction, and the MRI was helpful to disclose medial rectus slippage. So the surgery consisted of recovering the slipped muscle. I repositioned the medial rectus in its original insertion. I used non-absorbable sutures. I performed a conjunctival advancement in order to cover the buccal, and her A deduction improved. Another case, this was a male. He complained of diplopia and enophthalmos right after retinal detachment surgery. He had a traumatic right eye with retinal detachment 6 months earlier. He also had bad vision, a low vision on his left eye. He had 60 prism diopters, right esotropia, and the same eye was hypotropic. He showed severe enophthalmos, and thick and redundant conjunctiva. Post-duction test was positive. The MRI of the orbit again was helpful. It disclosed displacement of the buccal that was also displacing the right medial rectus up to the limbus. You can see here in this picture that the buccal is almost at the level of the limbus, like we can see in this drawing. Almost all recti muscles were displaced anteriorly, so the surgery consisted in the buccal removal, the stretching of the folded muscles, and the antimetabolites were applied locally. And his ductions improved remarkably. Another case, a male, he complained of long-standing intermittent diplopia, particularly when looking down. He had a left eye retinal detachment surgery at age 15, and he seemed to have a fourth nerve palsy with left superior rectus contraction, as you can see here. So the surgery consisted of the elongation of the left superior rectus with 2 marginal myotomies and right inferior rectus recession on adjustable sutures. The main question regarding this type of strabismus is to remove or not to remove the buccal. Sometimes the removal of the buccal is needed, but there's no clear agreement on this issue. Reported incidence of redetachment after buccal removal varies between 4 to 30% in different series. It is more frequent when removing encycling versus segmental buccals, and 50% of redetachments happens between 3 to 6 months after removal. We have to be aware of scleral degeneration. We have always to check the ocular fundus prior to removal of the buccal, because we can see this, we can see the buccal from inside the eye, as it happened to me with a patient, and it's not a good idea to remove the buccal in these cases. What options do we have if we don't want to remove the entire buccal? We can recess the muscle under the buccal. We can consider using hangback sutures over the buccal, but we might have doubts if the adhesion to the sclera will be okay in these cases. Or we can opt for a partial removal of the buccal and perform muscle surgery in a safe way. So, in conclusion, as treatment must be tailored to each particular case, we have to try to establish thoroughly the most probable cause of the deviation. In this way, imaging of the orbits could be helpful, and muscle surgery may be needed in many cases, but also other measures such as partial or total removal of the buccal, scarring removal, or conjunctival surgery are of main importance as well. If buccal removal is necessary, consider partial removal and ask the retinal surgeon opinion prior to do so. Also, we might consider just surgery on the other eye in order to match forces. Thank you very much for your attention.
Well, thank you very much. I would answer any question if there are questions from the audience.
Dr. Armesto.
Yes, Mario.
There is a question. Do you consider to remove the buccal sometimes? Do you wait for the retinal surgeon to approve the removal? What kind of address you have for those cases?
Well, I think it really depends on the origin of the strabismus. If the buccal is indeed causing any restriction of movement, we have to consider removing it. But as I said previously, you can remove it partially, not entirely, and always with the advice of the retinal surgeon, of course. Thank you.
And there is another question. And as my talk with high myopia, because these talks are related, And do you prefer to do handbags, or do you evaluate if you could do a fixus technique for recessions? What's your approach?
Well, the problem is that if you perform hangback sutures, maybe the muscle cannot attach properly to sclera. You don't know where the muscle will end. So if you can attach it directly to sclera, I think it's preferable to use that than hangback sutures.
Thank you, Dr. Armesto.
Thank you so much, Alejandro. That was a very interesting presentation. We now move on to the last speaker of our session, who is Professor Wang. He is from Taiwan, and he is going to talk to us on thyroid-related strabismus. Professor Guor, please.
Dear Dr. Sona Faspendi and Dr. Mario Najera and my dear colleagues in Mexico and around the world, I'm happy to join the IPOSC-AMOP combined webinar today. I'm going to talk about a treatment approach for thyroid strabismus. Diagnosis of thyroid eye disease, including the clinical examination and the laboratory test and the optoimaging. Surgical management of the thyroid eye disease should be done after the Q phase has resolved, with a minimum of observation for 4 to 6 months of stable strabismus measurements. Precision are used whenever possible, since the muscles are involved are often fibrotic and enlarged. For the hypertropia in thyroid eye disease, the first muscle to operate on is to recess the ipsilateral enlarged inferioritas muscle. We should remember to dissect the capsulopapillary head from the inferioritas muscle to decrease the postoperative lower lid retraction. We may check the distance between the limbus and the lower lid margin preoperatively. If there's enough space and there's no systemic contraindication, we should perform the operation under topical or local anesthesia. On-table adjustment is highly recommended. We should aim for a single binocular vision in primary and downgaze positions, which can be conducted by shifting the surgical tables. Let's look at our case. Case 1 is a 37-year-old female patient. She had a 35 present of right hypertropia with limitation of superduction and the enlarged right inferioritas muscle. She received the resection of inferioritas muscle for 7.5 millimeters with another handbag for 2 millimeters. Postoperatively, she was orthophoric in primary position with improved superduction in the right eye. Case 2 is a 79-year-old female patient. She had 30% of right hypertropia with severe limitation of superduction in the right eye. She received a resection of inferioritas muscle for 8 millimeters. However, she did not improve much after the operation. There is still limitation of superduction in the right eye. So she received a second operation for resection of superioritas muscle for 7 millimeters. She was also euphoric after the second operation, and there's improvement of superduction. However, there's myotosis after the operation. Compare with the case 1. Case 2 is an older patient with a smaller deviation angle. However, she received a larger dose, surgical dose, to achieve the same surgical outcomes. So we know that the normal muscle dose response curve may not apply in these patients. Since these muscles are generally stiff and elastic in thyroid eye disease, the initial 2 to 4 millimeters of resection has a minimal effect. As the resection gets larger, each additional millimeters may result in an increasing large correction. Larger than normal resection are usually necessary for small deviation, and the smaller than normal resection are advisable for large deviation. Patient's age may have an effect on the elastic nature of the involved muscle, which may result in different response curve. Case 3 is a 78-year-old female. She had a over 70 present of left hypertropia. There is a severe limitation of superduction in the left eye, and the left inferior rectus muscle is enlarged. She first received a resection of inferior rectus muscle for 8 millimeters and with another handbag for 4 millimeters in the left eye. After the operation, the condition did not change much. Which second muscle to operate on in a patient with residual undercorrection after maximal resection? We may choose to recess the contralateral superior rectus muscle, especially if they were enlarged. Another choice is to resect or plicate of the ipsilateral superior rectus muscle. This patient, we choose to resect the superior rectus muscle for 6.5 millimeter in the left eye. After the operation, the condition improved partially with improved superduction in the left eye. And she received the third operation to receive the resection of the superior rectus muscle in the right eye. And after the third operation, she was orthophoric in primary position with improved limitation in both eyes. We know that resection and plication is not the preferred procedure because it may cause more inflammation, more restriction, and there could be surgical difficulty. However, we may choose to resect or plicate the ipsilateral superior rectus muscle if there is severe proptosis or lid retractions. In this case, in procedure mainly of recessing the rectus muscle, it may displace the center of rotation of the eyeball further anteriorly. As you can see, after the first operation, the left eye becomes more proptotic. After the second operation, we resect the superior rectus muscle. You can see there is improved elevation. Also, the eyeball becomes less proptotic. So if we can combine the resection together with a resection of the antagonist, which may help to prevent anterior displacement of the center of the rotation of the eyeball. Case 4 is a 53-year-old female patient who had a 40% of left hypertropia. The superduction is only moderately limitation, and the left inferior rectus muscle is enlarged. She received a resection of inferior rectus for 7 millimeters with another handbag of 1 millimeter. And she also had a simultaneous resection of superior rectus for 6 millimeters. After the operation, she was orthophoric in primary position. However, there is a limitation of infraduction in the left eye. She had a diplopia in down gaze position, which prevents her from doing handiwork. Early overcorrection is a common sequela of inferior rectus resection. Severe overcorrection may be caused by muscle slippage or IR myotomy, especially if ipsilateral superior rectus muscle is involved. Mild overcorrection may be caused by overdose of combined resection and resection, especially in patients with relative younger age. Correction may require resection or fatal operation of the contralateral inferior rectus muscle. Let's go back and look at case 1 again. She was doing fine after the first operation. However, 2 years later, she developed right hypertropia for 30% diopter with limitation of infraduction. We thought there could be muscle migration, so we go in for the inferior rectus muscle. However, there's no muscle migration, so we detach and reattach the inferior rectus to 2 millimeters behind the original insertion site. After the operation, the condition did not improve at all. And we go back and look at the image, we found there is involvement of the right superior rectus and the left inferior rectus muscle. So she received the resection of left inferior rectus muscle for 8 millimeters. She was doing fine after the third operation. Late overcorrection could be due to muscle slippage, altered muscle dynamics. In our case, we did not find any muscle slippage or migration in the recessed muscle. The antagonist and the contralateral inferior rectus muscle were involved, both of which may contribute to the late overcorrection, which could be prevented by checking the asymmetric muscle involvement or the antagonist involvement preoperatively. In summary, we should aim for a single binocular vision in primary and downgaze position. Precision are used whenever possible. However, normal muscle dose response curve may not apply. For residual hypertropia, we may choose to resect or placate the ipsilateral superior rectus muscle, especially if there is severe proptosis or lid retraction. Early or late overcorrection may be prevented by careful preoperative clinical and orbital imaging assessment and the judicious on-table adjustment. Thank you for your attention. I will answer one question. I will answer one question from Dr. Chen Zhao that he asked me that would be overcorrection if we use handbag surgery on the inferior rectus muscle. We usually aim for the minimal dose of the recession in the inferior rectus muscle when using either the recession or handbag surgery, and that would be important to use the minimal dose to aim for the fusion at the primary and the downgaze position. So it is important, as Dr. Chen pointed out, that we should be careful not to give an overdose, so that would cause a overcorrection, especially when using the handbag procedures.
Thank you, Professor Guor, for sharing with us all the pearls for surgery in thyroid strabismus. We will now open the floor for discussion from all our faculty. It would be nice if everyone could unmute their mics and have that come up on the screen. I would like to address one question to Dr. Lewis. So it came from the audience. It's an interesting question. They say, what would you consider as the minimal age to operate on children with Brown syndrome, known that this condition can resolve with time?
Yes, I think we need to wait that the patient cooperation for the exploration. But I think if at 2 years we can see the abnormal head posture, or we can see that the hypotropia, it's a good idea to make the surgery.
So what's your age would be? Would you wait for like at least age 3 or 4 years? Or
yes, I think between 2 to 4 years we can make the diagnosis. And if we have, for example, there are a lot of patients who have a lot of a big abnormal head posture or a big hypertropia. I think if we are if we know that the diagnosis is correct, we can do the surgery.
Thank you so much. I'll now direct it to Alejandro. I think he has a question for Mario.
Yes. Thank you. Mario, regarding your case, the case you presented, do you consider sometimes just to cut the medial rectus when it's too tight, and just free the muscle in the orbit instead of performing a recession? Because sometimes big recessions are not enough to remove the restriction.
Yes, I have considered that, but I have always do a large recess, and if I find that the sclera is too thin and blue, I do a handbag procedure. I mean, even the large one. There have been Dr. Wright proposed that you might do a modified handbag with fiber glue in order to maintain the handbag not to move, because as you said, the handbag, you have no control where the muscle will be attached. But I used to do large medial rectus recess, at least 8 to 10 millimeters, and the string case, even 12, with the help of a medial rest plus a handbag.
Thank you, Mario. Any other questions from the group?
I would like to ask to Dr. Rohit about Duane syndrome. Dr. Rohit, I agree that the worst scenario or the worst appearance for Duane syndrome is always the up or down shoots. What kind of, I mean, have you seen that it can improve with just the lateral rectus recess, or you always do the medial rectus wide split surgery? I do that for those cases.
So the shoots are basically a release of the severe retractions. So if there are mild shoots, you can get away just by doing a large lateral rectus recession. You may not require a Y split. But if the shoots are very severe, then it helps, the Y split definitely helps in stabilizing the globe. And like I said, if there are very severe shoots, which are evident even in primary gaze or vertical deviation in primary gaze, then I would go ahead and do a periosteal anchor. So essentially, yes, if even recessions, large recessions of the lateral rectus would help to correct the shoots, but if they are very severe, it would, a Y split definitely adds to the stability of the globe in the post-op period.
Yes, I do the same. When I deal with a Duane syndrome patient without no severe downshoot or upshoot, I don't consider Y split. And when you do the vertical transposition, have you a vertical secondary deviation, and have you undone these transposition surgeries? Because it's hard to do.
Yeah, I usually now do the superior rectus transpositions instead of a partial vertical rectus transpositions after a lateral rectus periosteal anchor. Haven't had any significant vertical deviation, but I do not put a Foster's in a case of Duane's. I've had a problem of vertical deviation in a Duane's in which I had done a transposition with a Foster's. So I've stopped doing Foster's for ESO-Duane's, but I still continue to do so for a sixth nerve palsy. And I haven't seen any significant torsion or vertical deviation. But the key thing in transposition procedures is that you need to dissect the muscle even medially. So the superior rectus has to be dissected far back posteriorly on both lateral and medial side. And after you've done the superior rectus transposition, make sure that the attachment between the superior oblique and the superior rectus is nicely cut. Otherwise, the superior oblique gets pulled laterally along with the superior rectus. It's like, doing pulling the superior oblique temporally, just like a Harada Ito procedure or something, and that causes overaction of the superior oblique and encyclotorsion. So important in all transposition procedures to do good dissections and clear the muscle of all attachments.
Thank you. Any questions for Dr. Angor Wang and Dr. José Pérez from the audience, from the faculty and the group?
Yeah. For Dr. José, Dr. Fernando, we have done, we have applied botulinum toxin on Moebius patient, and our experience is that there will not be a good response. So when you do surgery on this isotropic Moebius patient, how far you go with the medial rectus recess?
Okay, thank you, Mario. Most of the times, the amount of the deviation is moderate. So only in cases with very small deviations, you can maybe try the Botox injection. But as I said, because of the muscle characteristics, there is no very good answer, very good effect of the Botox. So to do the surgery, the main issue is to do the force traction test, and you are going to try to negatize this duction test, so you can find out during the surgery where you can put the muscle when the duction test is already negative. So this is a dynamic type of surgery. You don't come with a pre-established millimetric plan, because during the surgery, you evaluate the amount of the stiffness and shortness of the muscle, and then you decide where to put the muscle to correct the deviation and get the primary position that you want.
Thank you so much. I have a question, just one last question before we close the webinar to Professor Angor Wang. Professor Guor, we have heard about the orbital surgeons in Taiwan and have seen some publications that at the time of orbital decompression, when in cases where there's a very tight inferior rectus causing a very large hypotropia, they may elect to just disinsert the inferior rectus. What is your experience about disinsertions in terms of stability of the result?
I think that would be one of the choice when you are facing a very difficult, very tight inferior rectus muscle. You may choose to just disinsert the inferior rectus muscle. However, in that kind of condition, you should first check if there's a enlarged superior rectus muscle on the antagonist. If there's a very also enlarged superior rectus muscle, when you disinsert the inferior rectus muscle, the eyes will be shooting up after the surgery. So that
Sure.
would not be a good surgical outcome.
Thank you so much. Thank you.
You're welcome.
Thank you so much to all the faculty. I think we are coming near the end. We will have Dr. Jason Yam and Dr. Mario help us to do the closing, please.
Dear colleagues, I would like to take this opportunity to introduce our next webinar. In May next month, we will have two webinars. The first webinar will be on the 1st of May. This time is with our Israel colleague and with the Israel Society of Pediatric Ophthalmology and Strabismus. And this time it will be a clinical challenges in pediatric ophthalmology and interactive case presentation. We will have a Faruk Orge from United States and Tamara Wanaski-Jeffrey from Israel to moderate for us. And also we have speakers from Spain, Israel, Abu Dhabi, United States, and Canada. So please join us. And this will be a very interactive webinar. And the next one is with our Philippine colleagues and with the Philippine Society of Pediatric Ophthalmology and Strabismus, and on retinoblastoma. We will be on May 21st. And we will have, among the star speaker from the Philippines and the world, and we have a special guest lecture from Dr. Carol Shield from United States. So please also mark your calendar and join us for this excellent webinar. Thank you. I will pass the mic to Mario for the closing remark.
Thank you, Dr. Jan. I would like to share a slide, and we as the Mexican Association of Pediatric Ophthalmology have been very delighted to participate, and we would like to thank again to the International Pediatric Ophthalmology and Strabismus Council for your invitation, especially to Dr. Faruk Orge, your president, and also to Dr. Sonal Farsabandi, our co-moderator and past president, and Dr. Jem and all the IPOSC board. And finally, I would like to remind that, as Dr. Luis Cárdenas said, on September, the International Strabismological Association will have his ISA meeting at the Caribbean Mexican at Cancun. So we hope to see everyone from all around the world in our country. The pandemic has been improving, and we are moving to the online Congress for the last maybe 2-3 weeks ago. So please, you are all welcome from all around the world to our country. And I would like to thank also to all the speakers for their excellent talks. And by saying no more, I would like to say thank you too much for being with us in this spectacular webinar. And I would like to say in some Spanish word for the end. Muchas gracias y hasta luego.
Thank you so much, Mario. And thank you very much to the audience for being very active and enthusiastic. Thank you to Dan and Michael for the excellent support from AAO as always. It would be impossible without you. And could we please request the faculty to just stay back for 2 minutes so that we could have the group picture, please? Thank you.
You're welcome, sir.